Good morning, everyone, and welcome to Cardiac Grand Rounds for, what is it, April, I don't even know, April 8th, 2025. Today, we're honored to have a visiting speaker from the University of Michigan. Dr. Jasmine Luzum is an expert in clinical pharmacogenetics with a particular interest in cardiology. She's a world-renowned expert, over 90 publications in this field, 2,200 citations, has worked on guidelines and scientific statements in this area for a while, so it should be a very interesting talk. Dr. Luzum's background is from the University of Pittsburgh, where she got her PharmD, North Carolina for her PhD, and then the University of Ohio for a postdoc. Last 10 years, she's been at the University of Michigan as an assistant professor. So, Dr. Luzum, welcome to Calgary, and we look forward to your talk on pharmacogenetics and cardiology.
Thank you, Dr. Howarth, for the introduction. Can you guys hear me okay on Zoom?
Yes.
Okay, all right. And thank you so much for the opportunity to come talk today. The title of my talk is "The Future is Now: Recent Advancements and Clinical Practice Guidelines for the Use of Pharmacogenetics in Cardiology." Here's my disclosure. So I am a member and guideline author for the Clinical Pharmacogenetics Implementation Consortium, also called CPIC. And if you haven't heard of CPIC yet, I will talk more about it later on. I'm also a member and scientific statement author for the American Heart Association, and I'm a consultant for a company called Aerial Precision Medicine. So here's the outline of what I'll cover today. I'll really briefly give you some background on what is pharmacogenetics. I will review the current clinical practice guidelines for pharmacogenetics of cardiovascular drugs. So clinical practice guidelines are very long and boring, so I'm just going to give you a very high-level summary of what are the main recommendations in the most recent guidelines. And so for the three drugs and drug classes I will review for you are metoprolol, clopidogrel, and statins. There's other cardiovascular drugs that have pharmacogenetic recommendations now, but for the sake of time, I'm just going to cover these three. These are some of the most commonly prescribed drugs in our field. And then I'll finish with some of the major recent changes that have been really advancing the clinical use of pharmacogenetics in cardiology. Some major advancements have happened just in the past few years that are really pushing the use of pharmacogenetics in clinical practice. So I'd like to give a shout out to Dr. Chad Bousman. So he reviewed my slides and gave me some advice on how to tailor these slides specifically to a Canadian and particularly an audience in Alberta. So I have tried to, obviously I'm most familiar with what's happening in the United States, but I have updated these slides with as much Canadian specific information as possible. So thank you, Dr. Bousman. So first, let's just get started with some brief background on what is pharmacogenetics. So the terms pharmacogenetics, pharmacogenomics, and even PGX, they're used interchangeably. They all basically mean the same thing. So pharmacogenetics is the field of research and clinical practice that assesses how patients' genetics influence their responses to drugs. So we know there are many things that affect how our patients respond to medications. So there's biological factors like the patient's age, sex, kidney function, liver function, and even what other medications are they on. So, for example, taking into account drug-drug interactions. There's also many environmental and social factors that we especially need to take into account in the US. For example, can my patient afford this medication that I'd like to prescribe for them? Does their insurance plan cover it? Even thinking about their neighborhood, is there a pharmacy in their neighborhood? Can they even get this medication I'd like to prescribe for them? So there's been a lot of hype recently about this new concept of precision medicine, precision health, but really I don't think precision medicine is a new thing. I think we already practice precision medicine. We tailor the patient's medication regimen to what's best for them. It's just that genetics is a different aspect, a different biological factor that we also should be taking into account when we're prescribing medications to our patients. And really, the effects of the genetic variants on how patients can metabolize these medications, it's actually really similar to how drug-drug interactions affect how patients respond to their medications. So pharmacogenetics, it might be a new term, but it's really not a completely new concept, just like precision medicine isn't a completely new concept. And when I talk about the 3 drug examples, I think that'll highlight more like what exactly is pharmacogenetics. So that's my brief background on what is pharmacogenetics. And so now I want to review what are the current clinical practice guidelines for pharmacogenetics of cardiovascular drugs. So the first question is, where do clinical recommendations for cardiovascular pharmacogenetics come from? There's actually lots of places now. So it used to be that we didn't have any resource for clinical practice guidelines, and now it's almost like the pendulum has swung too far the other way, and now we're getting pharmacogenetic recommendations from multiple different organizations. So on the left here, under PGX, these are pharmacogenetic specific organizations. So they're mostly focused on pharmacogenetics, and so they're not in any particular therapeutic area. So they make pharmacogenetic recommendations across therapeutic areas, from psychiatry to infectious disease and cardiology. So the one on the top is CPIC, the Clinical Pharmacogenetics Implementation Consortium. So this is an international organization. There's also the Canadian Pharmacogenomics Network for Drug Safety. So I saw they've published some pharmacogenetic clinical practice guidelines. DPWG is the Dutch Pharmacogenomics Working Group. These are pretty famous clinical practice guidelines. And RNPGX is the French National Organization for Pharmacogenetic Guidelines. In the middle are some of the regulatory agencies. So their primary job is to make sure that medication use is safe and effective for whatever country they're located in. So on the top is the US FDA. So they maintain a list of all drugs that have pharmacogenetic information in their FDA approved label now. And that list is actually over for 300 drugs now. And that I think right now for cardiovascular drugs, it's maybe 15 drugs total. Also, Health Canada has started integrating pharmacogenetic information into their approved labels. The European Medicines Agency, EMA, the Swiss regulatory agency, Japanese. So lots of different regulatory agencies are starting to incorporate pharmacogenetics now. And then on the right, we have your therapeutic specific area like organizations. They're publishing their own guidelines. So I put some of the cardiovascular ones on this slide. So for example, the American Heart Association, American College of Cardiology, the Canadian Cardiovascular Society, I saw their guidelines online, and also the ESC. So I did search the Canadian Cardiovascular Society guidelines for the recent guidelines, and found that they hadn't mentioned pharmacogenetics yet for any of the drugs that I'm going to cover today. But Dr. Bausman told me that the stroke guideline actually does mention CYP2C19 and says to consider pharmacogenetic testing for when using clopidogrel for stroke. So all these different organizations with different guidelines has actually made it quite confusing and challenging for clinicians who are trying to start using pharmacogenetics. So one resource I wanted to point out was PharmGKB. This stands for the Pharmacogenomics Knowledge Base, and I have the URL at the bottom of the slide, and I'm happy to share my slides if anybody would like them. So PharmGKB is the best and central resource for any pharmacogenomic information you would like to know. And they also annotate any recommendations from any of these pharmacogenetic organizations and any of these regulatory agencies. So for example, if I want to know what are the current recommendations for metoprolol, you can search metoprolol on PharmGKB, and it'll give you a summary if any of these organizations have recommendations. So it's a nice resource for clinicians. Unfortunately, PharmGKB hasn't started annotating any of the therapeutic area specific guidelines, a few, but not any of the cardiovascular ones. So you would still need to search the cardiovascular guidelines themselves, which I have done. So I don't have time in a 1-hour seminar to review all of the different recommendations. Today I'm going to focus on summarizing CPIC's recommendations for you. So when we've actually studied and compared the recommendations across these organizations, and they only agree about half the time. So what the health systems in the US, if there's any disagreement between, for example, what FDA or AHA and CPIC says, they are defaulting to CPIC's recommendations. So CPIC is the primary resource that health systems in the US are following for their pharmacogenetic implementation programs. So that's why I'm going to summarize CPIC recommendations for you today. So what are the current clinical practice guideline recommendations for metoprolol? So really briefly, let's just review how can genetic variants affect patients' response to metoprolol. So I'm sure everyone in this room is familiar with metoprolol. This is the number 6 overall most prescribed drug in the US, used to treat a variety of cardiovascular and non-cardiovascular indications. So the primary pharmacologic effect of metoprolol is to inhibit beta-1 receptors in the heart to decrease heart rate. So how does metoprolol exit the body? So how does the body metabolize metoprolol? So metoprolol is primarily metabolized by an enzyme in our liver called CYP2D6. And some of our patients, and some of us in this room, our DNA encodes for a CYP2D6 that doesn't work. So as many as 7%, well, it seems like something happened with the font when it was uploaded to this computer. But up to 7% of patients can have a genetic variant that encodes for non-functional CYP2D6. So this means they are not metabolizing metoprolol. So they have much higher blood levels of metoprolol, which means they could be much more sensitive to low doses of metoprolol and they're at risk for having dramatically lower heart rates, even on low doses of metoprolol, and at risk for bradycardia. So this has been shown in many studies now. I've cited just 3 examples for you here. So what do the clinical practice guidelines recommend, like knowing this effect? So if you order a pharmacogenetic test for your patient, the results will come back to an estimated, what is the genetically determined CYP2D6 metabolism for this patient? So patients could generally fall into 4 different categories of CYP2D6 function. It could be ultra rapid on one extreme, normal, intermediate, which means their CYP2D6 enzyme works about half as well as normal, and then the poor metabolizers, which means their CYP2D6 enzyme actually doesn't work at all. So if your patient is an ultra rapid, normal, or intermediate metabolizer, they are able to metabolize metoprolol. So there's really could be any standard beta blocker selection and dosing. But it's the minority of patients who happen to be these poor metabolizers where we'd want to be more careful about how we're prescribing metoprolol. So it's recommended to initiate it at the lowest possible starting dose and more carefully monitor for bradycardia and at any dose increases. So that's the main recommendation from this guideline that was published just last year. So these genetic variants in CYP2D6, they really only have a strong effect on metoprolol and not other beta blockers. So that's why for beta blockers other than metoprolol, there's really no recommendation of genetic variants that we know of that have a strong effect yet. There were hundreds of studies we reviewed for this guideline, including other genes, so including, for example, the drug target. ADRB1 encodes the beta-1 adrenergic receptor. So because of genetic variation, all of our beta-1 adrenergic receptors are not the same. So it's not surprising that people respond differently to beta blocker therapy. But the effects of genetic variants in any of these other genes, it was not really consistent or strong. So again, no recommendations for any other genes. So when the reviewers criticized this guideline because they're like, most of this is just no recommendations. Like, this isn't really useful. We're only making one recommendation for one beta blocker. But we thought it was important to say, we did review the evidence and it wasn't strong enough to change clinical practice at this time for any other beta blocker or any other gene. Because there were a lot of genetic testing companies opening in the US, and they're selling genetic testing to providers and patients saying, this gene is going to affect how you respond to this beta blocker. So we thought it was important to put in the guideline that actually, no, this evidence it's based on weak evidence. So I have some review questions in here. The first one is, patients that have genetically determined poor CYP2D6 function have increased risk of bradycardia with which of the following beta blockers? Is it A, atenolol, B, bisoprolol, C, carvedilol, D, metoprolol, or E, all of the above? So we're going to do this the old-fashioned way with hand raising in the room, and those of you on Zoom, feel free to respond in the chat. So who thinks it's A, B, C, D, or E? So you guys are paying attention this early in the morning. All right, yes, correct answer is D, metoprolol. Okay, so that's a summary of the main recommendations for beta blockers. It's just metoprolol and CYP2D6. So the next example I wanted to cover was clopidogrel. So we know clopidogrel is a P2Y12 receptor inhibitor, antiplatelet drug. What's kind of unique about clopidogrel, it is a prodrug. So that means the drug molecule that's in the tablet that the patient takes is inactive. It's not an active platelet inhibitor. It first needs to be activated in the body in order to inhibit platelets. So how is clopidogrel activated in the body? It's primarily activated by an enzyme in our liver called CYP2C19. But some of us in this room and some of our patients, our DNA encodes a non-functional or decreased function CYP2C19 enzyme. So as many as 30% of patients, so almost 1 in 3, depending on what their ancestry is, they could have one of these genetic variants that causes decreased CYP2C19 function or complete loss of CYP2C19 function. So patients with these genetic variants, they're not activating clopidogrel. This has been, so even if they're very adherent to their prescription, they're taking clopidogrel every day, they are still at very high risk of heart attack or stroke while taking clopidogrel. And here's an example of some of the studies that have shown this. So what are the current clinical practice guideline recommendations for pharmacogenomics for clopidogrel? So again, depending on what the patient's genetically determined CYP2C19 metabolism is, it could be ultra rapid or rapid, normal, intermediate, or poor. So if the patient has ultra rapid or normal CYP2C19 function, they're able to activate clopidogrel. So this would be just standard clopidogrel selection and dosing. But it's the approximately 30% of patients who could have intermediate or poor CYP2C19 function where it's recommended to avoid clopidogrel if possible and prescribe an alternative antiplatelet depending on what the indication is. So it could be prasugrel or ticagrelor. Because these genetic variants in CYP2C19, they don't really affect the other P2Y12 inhibitors. Also, there are lots of other studies looking at these other genes or targets for clopidogrel. And again, the evidence wasn't consistent or strong, so no recommendations for any other genes at this time. So here's the next review question. Clopidogrel should be substituted with an alternative antiplatelet medication in which of the following patients? A, CYP2C19 ultra-rapid metabolizers, B, intermediate metabolizers, C, poor metabolizers, or is it A and B, or B and C? So who thinks it's A? B, C, D, or E? All right. Yes, correct answer is E. So patients who are CYP2C19 intermediate and poor metabolizers, they're not really activating enough clopidogrel. All right, so the last drug class example I wanted to talk about was statins. So how can genetic variants affect patients' response to statins? So in the statin case, I'm more focusing on the main adverse effect of statins, which is muscle pain and myopathy, that's the #1 reason why patients don't want to take their statin. So this is not, the evidence for statin effectiveness or LDL lowering isn't actually that consistent. So the primary pharmacologic effect of statins is to inhibit the enzyme HMG-CoA in the liver to cause decreases in LDL cholesterol. The liver is also the main site of metabolism for most statins and how they're excreted from the body. So how do statins get into the liver? Most statins are primarily transported by an enzyme that's encoded by a gene called SLCL1B1. And again, there's genetic variants that cause SLCL1B1 to not work in some of us or have decreased function in some of us. So as many as 30% of patients, or 1 in 3, can have one of these genetic variants that causes decreased or poor SLCL1B1 function. So if their enzyme is not transporting the statin from the bloodstream into the liver, that means these patients with these genetic variants, they have much higher blood levels of statins. That means more exposure to their muscles and increased risk of muscle pain. And this has been shown in multiple studies now. What is more complex about statins compared to the 2 previous drug examples, those were much more simple. It was basically one drug, one gene effect. Statins, it's a little more complex because different statins are affected by different genes to different extents. So the effects of genetic variants in this gene, SLCL1B1, are by far strongest on simvastatin. Simvastatin has the strongest substrate specificity for this transporter, and also pretty strong effects on pitavastatin and atorvastatin, but much smaller effects on rosuvastatin and fluvastatin, for example. So you might be thinking, well, why don't we just use rosuvastatin and fluvastatin in everyone, and so we don't have to worry about this genetic variant? Well, rosuvastatin and fluvastatin, they're transported by other enzymes, which also have genetic variation. So here's rosuvastatin. That's transported into the liver by an enzyme encoded by the gene ABCG2. And 9% of patients with East Asian ancestry have genetic variants that can decrease ABCG2 function. So patients with these ABCG2 variants, they have much higher blood levels of rosuvastatin compared to patients who don't have these variants. And this has been shown in multiple studies. And then for fluvastatin isn't so much dependent on these transporters, but it is metabolized by CYP2C9 in the liver. And approximately 14% of patients have genetic variants that can decrease CYP2C9 function, dramatically increasing their blood levels to fluvastatin. So the statins, it's much more complicated. There's multiple genes affecting multiple statins in different ways. So how we wrote the pharmacogenetic guideline, we basically overlaid the pharmacogenetic recommendations on top of like the AHA cholesterol treatment guidelines. So the way the AHA cholesterol treatment guidelines are organized is by intensity of statin. So this is the statin doses that are high versus moderate versus low intensity, and you match the intensity of the statin treatment to their risk for ASCVD. So we subcategorized what was already in the AHA cholesterol treatment guideline by the effects of the genetic variants. So for example, if my patient needs a high intensity statin and they happen to have SLCL1B1 poor function, you would want to select which statin within these groups has the lowest risk of SAMs, or statin-associated muscle symptoms. So for example, in this case, if your patient is SLCL1B1 poor function, that would be rosuvastatin 20, would be the lowest risk of SAMs. Here's the recommendations are similar if it's SLCL1B1 decreased function. If the patient has genetically determined ABCG2 poor function, that's the one where you would want to dose rosuvastatin more carefully or use a different statin. And if they have genetically determined CYP2C9 intermediate or poor function, you would dose fluvastatin more carefully or select a different statin. The evidence for any other genes was not strong enough to make any clinical recommendations at this time. So here's our next review question. Genetic variants in which of the following genes significantly increase patients' blood levels of statins? A, SLCL1B1, B, ABCG2, C, CYP2C9, D, all of the above, or E, none of the above. So who thinks A, B, C, D, or E? Correct answer is D. So multiple genes are affecting different statins. All right, so that was my very high level summary of like what are the main recommendations right now for some of our most commonly prescribed cardiovascular drugs. So I did want to take some time to discuss some of the major changes that have happened recently that are really advancing the clinical use of pharmacogenetics. So I've been in this field for 15 years now, and there has been a lot of skepticism from cardiologists about, why we should start doing this in clinical practice. So one of the first things that cardiologists will tell me is, well, there aren't any prospective randomized controlled trials, or RCTs, showing that using pharmacogenetics significantly improves clinical outcomes for patients with cardiovascular disease. So it was true, but it's no longer true. Now there's multiple randomized controlled trials that show clinical utility for pharmacogenetics for cardiovascular drugs. So what these randomized controlled trials did is they basically randomized patients to genetic guided cardiovascular drug therapy, so several different cardiovascular drugs, versus our current standard of care, but we don't take into account the patient's genetics when we're prescribing cardiovascular drugs. And so now multiple randomized controlled trials have shown that the patients who are randomized to the genetic guided group had significantly improved clinical outcomes. And these are hard outcomes like MACE, and then also severe adverse drug reactions too. So I don't have time to review all of these landmark trials, so I have some screenshots in here for you. So this was the Popular Genetics trial published in New England Journal in 2019. This was for platelet inhibitors. Also, this is the UPAC trial for genotype guided dosing of warfarin published in New England Journal in 2013. This was a randomized controlled trial in China about antiplatelet therapy. Also the PharmCo trial, and the GIFT trial was warfarin dosing published in JAMA. So the trial that I, for the sake of time, I just wanted to highlight one, and that's the PREPARE trial. So this is the most recent one. It was published in Lancet a year and a half ago in 2023. And this was a 12-gene pharmacogenetic panel to prevent adverse drug reactions, an open-label, multi-center, controlled, cluster randomized crossover implementation study. So the PREPARE trial was done in Europe by a group called UPGX, or the Ubiquitous Pharmacogenomics Group. So this trial was done in 7 different European countries, colored in red on this map, and the white stars were the main coordinating site of each country. So patients were randomized to genetic guided drug therapy versus standard of care. So the patients who were randomized to genetic guided drug therapy, they did a pharmacogenetic test, and they were each given this card, like a business card with this QR code on it. And it says, to the healthcare provider, please scan the QR code to view pharmacogenomics-based drug dosing recommendations for this patient. So the provider could scan the QR code and they would see the patient's pharmacogenetic test results on their mobile device, or they could flip to the back side of the card and see a summary of the patient's pharmacogenetic test results. So for example, this patient is Jane Doe. She happens to be a CYP2C19 4 metabolizer, and the critical drug substances where a modification would be recommended for this patient includes clopidogrel and sertraline. She's also a CYP2D6 ultra-rapid metabolizer, which affects many different drugs. She's a TPMT poor metabolizer. And the other genes tested are not actionable. So she basically has normal enzyme function for this list of other genes at the bottom. So you can see there's, these same drug metabolizing enzymes, they metabolize lots of different drugs, not just cardiovascular. So here we are in cardiovascular grand rounds. So why am I talking about this trial in particular? Well, because of the prevalence of heart disease, the most commonly used medications in this trial were cardiovascular drugs. So atorvastatin was the #1 most prescribed drug. Clopidogrel was #2. Simvastatin was #4. And then also warfarin and metoprolol and acetylcoumarol were in the top 20. So really predominantly cardiovascular drugs used in this trial. So the PREPARE trial included nearly 7,000 patients, half randomized to genotype-guided drug treatment, half randomized to standard of care. There was, oh, sorry, the fonts got a little messed up, but there's 12 weeks of follow-up total. The primary outcome was causal and clinically relevant adverse drug reactions. So they weren't looking at drug effectiveness, just adverse drug reactions. And how they used established, validated tools to determine the causality of the adverse drug reaction. So was this bad thing the patient reporting, how likely was it actually due to the drug versus something else? Like, is their muscle pain due to the statin or did they have a fall? So first they determined likely causal adverse drug reaction, and it had to be clinically relevant. So I think the clinically relevant definition meant like it at least prompted an interaction with a healthcare provider. So the rate of the primary outcome in the genotype guided drug treatment group was 21.5%, and in standard of care it was 28.6%. So this resulted in an odds ratio of 0.7, which was statistically significant. This means there was a 30% relative risk reduction in adverse drug reactions, a 7.1% absolute risk reduction, and this translates to a number needed to test of 14 to prevent one clinically relevant adverse drug reaction. So if we do pharmacogenetic testing in 14 patients, we are likely to prevent one clinically relevant adverse drug reaction in 12 weeks. This is huge. I mean, considering the cost of the management of adverse drug reactions, so improving the quality of our patients' lives, also saving our healthcare providers time, this could have huge public health benefits. So this is a really sad statistic. The adverse drug reactions are the 4th leading cause of death in the United States. So this is what is reported by the FDA. So more Americans are dying from adverse drug reactions than diabetes, than automobile accidents. So adverse drug reactions are a huge public health problem in the United States. I wasn't able to find data to confirm this in Canada as well, but there was lots of data showing that adverse drug reactions are a significant public health problem in Canada too. So an estimated 200,000 adverse drug reactions occur in Canada each year, resulting in thousands of hospital admissions and deaths. And the annual cost of adverse drug reactions has been estimated to be over $13 billion in Canada. So with this PREPARE trial, it was really exciting that now we have prospective randomized controlled trial evidence showing that using pharmacogenetics significantly reduces patients' risk of adverse drug reactions. So now that we established there's multiple randomized controlled trials, the next thing cardiologists would tell me is like, well, these tests are just too expensive. Like our patients can't afford it. So the cost of genetic testing with improved technology has really gone down in recent years. Like you can sequence a person's entire genome for less than $1,000. And if we're talking about a single pharmacogenetic test, like say you just want to test CYP2C19 because your patient needs an antiplatelet drug, a single pharmacogenetic gene test cost is approximately 200 Canadian dollars. If you wanted to do a multi-gene panel, like what they did in the PREPARE trial, multi-gene panels cost approximately 500 Canadian dollars. So the best data I could find to compare this to other tests we routinely and repeatedly perform in cardiology. For example, a BMP is $40 to $50, and a lipid panel is $99. So the thing that's unique about genetic testing is our DNA doesn't change. Our DNA is the same our whole life. Your BMP and your lipid levels, those can change. So those usually need to be measured repeatedly. And also because our DNA doesn't change, you can do the test before you start the medication. So unlike most clinical lab tests, genetic test results typically don't change over someone's lifetime, and they can be performed before the patient starts taking the drug to assess their risk. So for example, what we kind of do right now for statins, we start a patient on the statin, they complain about muscle pain, you might order a creatinine kinase or CK to see like, is there actual true myopathy happening with this patient? And then you adjust statin therapy accordingly. On the other hand, with a genetic test, before you start that statin, you could do that SLCO1B1 test and then decide this is the statin with the lowest risk of SAMs for this patient. And then hopefully you would prevent that muscle pain from happening in the patient. So that is one major advantage of genetic test results versus other kinds of biomarkers we routinely use in clinical practice that can change. So low cost was another barrier recently overcome. So the next thing prescribers will tell me is like, well, my health system doesn't offer the pharmacogenetic testing, so I'm not able to order it. This is not true anymore either. There's really improved availability of pharmacogenetic testing. So many more health systems are offering pharmacogenetic testing now. And also, there's many commercial labs that offer it too. So if you could send out the patient sample for genotyping. So like I said, many more health systems are now implementing it. So I was a postdoc at Ohio State University. And in 2011, the PGRN, which is the Pharmacogenomics Research Network, did this TPP, which is Translational Pharmacogenetics Program, where they were evaluating the earliest adopter health systems that were actually implementing pharmacogenetic testing. So these 6 pictured here were the early adopters of pharmacogenetic testing. Does anyone want to guess? So we had 6 in 2011. Anybody want to guess how many are implementing pharmacogenetic testing in the US now? So now in 2025, it's approximately 70. So really has like increased in popularity in the US. So the screenshot in the bottom right corner is from the CPIC website. They keep a list of any health system that says they are implementing pharmacogenetic testing. So about 70 of those are in the US now, and they have a contact person at each of those health systems who's in charge of that pharmacogenetic program. And on total on that list, it's over 115 health systems worldwide who say they're implementing pharmacogenetic testing. And if you don't already know, this includes University of Calgary. Not in cardiology yet, but Dr. Bausman has established a robust pharmacogenetic testing program for pediatric psychiatry. And also just started a clinical trial implementing clopidogrel CYP2C19 pharmacogenetic testing at Foothills Medical Center, just launched for antiplatelet prescribing in 225 stroke patients. So it's got this nice little acronym, PGX Safe. I like the little logo. So he's already broken down barriers and figured out, overcome like many of the challenges for okay, this is great. How do we actually start implementing this in the health system? So Dr. Bausman has already overcome many of those barriers in doing it. There's also commercial labs that offer pharmacogenomic testing. So the NIH has this genetic testing registry where you can look up any kind of genetic tests that you might be interested in ordering, and it'll show you which labs do it. And the results can be filtered by country. So this is a screenshot where I searched for pharmacogenomic tests in the genetic testing registry. And on the results, it shows there's, in the blue box, there's 12 total human test results available. And on the bottom, I filtered by Canada. So 12 different pharmacogenetic tests offered from 4 different laboratories. And only laboratories that have submitted their information to this registry get on the registry. And Dr. Bausman said there's actually 15 commercial labs across Canada that now offer pharmacogenetic testing too. So this is another barrier that's been overcome. There's lots of different labs now offering pharmacogenetic testing. But if, the next thing providers tell me is like, well, if I can order the test, there's no place for me to put it in the EHR. Also, this is not true anymore. So there's lots of different software that have been developed to help integrate genetic testing into patients' electronic health records. And this also includes Epic. So Dr. Bausman told me that Alberta Health System now uses Epic. We also use Epic at the University of Michigan. But he said pharmacogenomic results are placed in the media tab at the moment. That's also where we started putting pharmacogenetic test results until there were different ways to do it. So when our providers would order a pharmacogenetic test, the results would, at an outside lab, the results would come in just a PDF, which was scanned and then uploaded to the media tab. So this the main problems and challenges with this was first, a lot of our providers didn't even know that's where it was. It also couldn't be integrated with providing any alerts to the prescribers, like if they wanted to prescribe a potentially high-risk medication if the patient already had their genetic test results. Also, we weren't able to push the results out to the patient portal when all this was in the media tab. So Epic itself now offers its own tool, a place to put genomic test results in the patient's chart. It's called Genomic Indicators. So I know Epic is different at every health system. Our version of Epic we call MyChart. And so providers, if they want to know, are there any genetic test results, they can just search for genomic and they could jump to Genomic Indicators. So this is a screenshot of what the Genomic Indicators results could look like. So first, does the patient have any genetic variants causing an inherited disease? So like this patient does have genetic familial hypercholesterolemia. And then under any disease genetic test results are the drug test results. So this patient happens to be a CYP2C19 normal metabolizer. And here's what our existing clopidogrel pharmacogenomic alert looks like in MyChart. So if the patients have a CYP2C19 intermediate or poor metabolizer result already available at the time of post-PCI order set entry, they would have this yellow pharmacogenomic warning. So when the provider goes to choose the antiplatelet therapy, clopidogrel is the most common at our health system, so that's why it's on top. But here's an example where the patient, their CYP2C19 IM or PM. It says, based on pharmacogenetic testing, this patient is expected to have reduced response to clopidogrel. Consider use of an alternative antiplatelet agent. Please consult your treatment team pharmacist or the pharmacogenetics service. So we actually have 2 pharmacists who run a pharmacogenetics service to help any of our providers who may have questions about any of the pharmacogenetic testing. And we can also push, with genomic indicators, you can also push the patient's genetic test results to the portal, their patient portal, if they request it. So now there's places in the EHR and clinical decision support for genetic testing. But providers, another thing they tell me is like, well, it's still just not recognized as the standard of care. Well, there's been really increased public and patient awareness of pharmacogenetics due to some high-profile lawsuits that have happened recently. So even though providers were like very slowly, very carefully implementing pharmacogenetics in clinical practice, it's almost as if the patient and the public is like pushing for it faster than what we are implementing it. So here's a screenshot of one of those high-profile cases. So it says OHSU to pay $1 million, promises change to settle lawsuit from widow of cancer patient. So OHSU is for Oregon Health and Science University. So the man in this picture, David McIntyre, he had cancer and was treated with chemotherapy, which has a rare but potentially life-threatening adverse reaction. There is a pharmacogenetic test that can detect if you have a variant that increases your risk of that rare and potentially fatal adverse drug reaction. He was not tested for it. He had this adverse reaction and he died from it, from the use of chemotherapy. So this is a really sad story. You know, he died from his treatment, not from the cancer. And it could have been prevented with a pharmacogenetic test. And his wife was aware of the availability of this pharmacogenetic test, so she sued OHSU and won. And now this pharmacogenetic test is standard of care at their health system. But this is a cancer example, you know, it's like, it makes sense. This should be done in cancer. But what about cardiology? There was a really high profile case that brought attention to cardiology pharmacogenetics too. So this headline says, Bristol Myers Sanofi ordered to pay Hawaii $834 million over the Plavix warning label. So what happened in this case, so Bristol Myers Sanofi makes Plavix, brand name clopidogrel, and those genetic variants in CYP2C19 that cause CYP2C19 loss, decreased function are most common in people with Oceanian or East Asian ancestry. And since the majority of the population of Hawaii is Oceanian or East Asian ancestry, the state attorney general of Hawaii basically said to the company, you're selling an ineffective drug to the majority of the citizens of the state of Hawaii, and you know it. And the state of Hawaii won because they had many of their citizens were taking the clopidogrel and they were still suffering from heart attacks and strokes. So this was a big high-profile case demonstrating the importance of pharmacogenetic testing for a cardiovascular drug too. So here's my last review question. Which of the following major recent changes have facilitated the clinical use of pharmacogenetics? A, we now have prospective RCT evidence showing pharmacogenetics significantly improves patient outcomes. B, there's low cost of pharmacogenetic testing. C, there's improved availability of pharmacogenetic testing. D, there's availability of pharmacogenetic testing in the EHR, or E, all of the above. So who thinks A, B, C, D, E? Great. Yes, all of the above. So if our finish line here is to just make genetics, a normal part of cardiovascular clinical practice, what are the remaining hurdles? I feel like we've come a really long way. We are almost there to making this a reality. So we now have randomized controlled trial data. We have tests available. There's low cost, and reimbursement was probably the biggest hurdle in the United States. Because now Medicare will cover pharmacogenetic testing. Medicare is our largest insurer in the US, and also several different private healthcare insurances also now cover pharmacogenetic testing. So we've overcome that hurdle. There's now integration, EHR, and clinical decision support, and there's clinical practice guidelines available. So what are the two major remaining hurdles? So she's jumping over clinician awareness right now, which is why I'm teaching here today, because we are addressing this hurdle right now, and now you guys are aware of what pharmacogenetics could do in cardiology. And the last remaining hurdle, I think, is resources for implementation. So in the health systems in the US where I've seen this is actually done well, and done like across the healthcare system with widespread implementation, that has come from a significant financial investment from the top down in the health system. So I think resources for implementation are the last remaining hurdle. So that's everything I wanted to cover today, just some quick summary points. Pharmacogenetics is the field of research and clinical practice that assesses how patients' genetics influence their responses to drugs. Many patients have genetic variants that decrease their ability to metabolize some of the most commonly prescribed cardiovascular medications. Today I covered metoprolol, clopidogrel, and statins. And many major recent changes have greatly facilitated the clinical use of pharmacogenetics. Metoprolol should be dosed more carefully in patients that have genetically determined poor CYP2D6 metabolism. Clopidogrel should be avoided in patients that have genetically determined intermediate or poor CYP2C19 metabolism. And statins with the lowest risk of SAMs, or statin-associated muscle symptoms, should be selected in patients with genetically determined decreased or poor function in SLCO1B1, EBCG2, or CYP2C9. So I have to give a shameless plug for our genetic certification course offered by the American Heart Association. If you're interested in learning more about how to start applying genomics to cardiovascular clinical practice, this online course is called From Concepts to Practice, a guide to cardiovascular genomics, which can be purchased for the low price of $249 US. Thanks to Dr. Bausman for teaching me about the status of pharmacogenetics here in Alberta. Amisha Kalma, who also helped me with my slides. I work with many different organizations, and NIH funds the research from my own lab, and hopefully NIH will still be around. Yeah. And thank you all for your attention. Happy to answer questions.
Thanks so much for that wonderful talk about translation of cardiogenomics. That's wonderful. We'll open the floor to questions. Catherine.
You answered a lot of my questions, but one that's left is how long does it take to get the test? If you got a patient coming in, going to the cath lab, you want to start them on clopidogrel, or how long do you take before you get that test back?
I wish I uploaded the picture to my slides. I could show them. There is a point of care test now available on Dr. Bausman's clinical trial in implementing it in stroke right now. You can get test results back in as little as 1 hour. And it's not a blood sample, it's a buccal swab. So that's the fastest availability now. What a lot of health systems are doing is called preemptive pharmacogenetic testing. So, you know, if patients are prescribed like a certain medication or if they're in a certain service, they'll just do the whole panel and then they'll have all those results available so that like down the road, the results are already in the EHR if any of those medications are prescribed in the future. So actually I think the preemptive testing it's the most cost efficient and fastest available. And then there's the point of care testing. We do most of our testing as send out actually to Mayo Clinic, and it can take 2 weeks. So it depends on, you know, which medication it is, how fast you need the results back. A lot of prescribers, like, they won't wait for those test results. They'll start a medication, and then once they get those results, they may change it. So yeah, it depends.
I was almost thinking it'll be done when you get your baby and it goes home with the baby.
It's not, yeah, I mean, it's not included with newborn sequencing yet, but we do, yeah, newborn genetic testing for lots of other things.
Anwar?
Thank you very much. It was very interesting. The study you showed for the randomized control trial,
Yeah.
2013, it's like more than 10 years now.
Mm.
I was surprised. I mean, even after you test, we had 21% adverse, 21% people had adverse reaction. Versus if you don't test, it's 28, right?
Yes.
I was expecting it to be a little bit more after all this kind of, maybe it's different now.
So the PREPARE trial, that was published 2023. And I mean, I'm actually not surprised by that adverse event rate. I mean, like the statistics says that adverse drug reactions are the 4th leading cause of death in the United States.
When you test, you're still 1 in 5 have a chance of getting.
Yeah. So, I mean, there's lots of other things that can cause adverse drug reactions. That's why I start with like genetics is just one piece of like what we do. So yeah, they could be having adverse drug reactions for a lot of other reasons, but genetics can help reduce some of that risk.
I'll ask a question. So in cardiology, we tend to start a lot of agents on patients with heart failure, post-MI. Drug-drug interactions. Can pharmacogenomics help inform risks in drug-drug interactions? Is that a potential role for them?
Yeah, so that's one thing I actually didn't cover is because you could have a patient could have genetic variants affecting that metabolizing enzyme. Plus, they could have other drugs that are inhibitors or inducers of that enzyme. So there has been some studies that have investigated, how bad is the combination of those two things, like if the patient has a genetic variant and a drug-drug interaction or just one of the other. There's not as much data in that field, but I mean, the effects we see on like pharmacokinetics for the genetic variants is, similar to or sometimes even more extreme than the drug-drug interaction. So it's reasonable to assume that, yes, both of those things could affect the patient. We need to consider both, I think.
Any questions online? Please feel free to enter in the chat or speak up. If not, we're actually at the top of the hour. So I want to thank you, Jasmine, for coming. That was